Good afternoon, everyone, and thanks a lot for joining today's webinar. So this is something that we have wanted to be treating for a while, the role of diabetes educators, of diabetes coaches around the world. So we know that in our networks, both in YLD and in BCB, we have a lot of people that are actually diabetes coaches or diabetes educators. So we really wanted to know your perspective and how the role changes around the world. So today we are going to have 3 speakers, which we are going to introduce in a while. But first, we just wanted to discuss a bit with you diabetes education. Everyone knows that this is key for people living with diabetes and their carers, and also for the people at risk of diabetes, of type 2 diabetes. Education is needed at all stages of life, so it's not only something that people need to receive when they are diagnosed, but also throughout their lives. It's something very important because diabetes care, diabetes management change, and people need to be educated at different moments of their life. We know that diabetes education is very heterogeneous around the world. There are countries that are doing very well, and there are countries that are doing not that well. So unfortunately, the level of education that people may have about their condition and its management differs a lot depending on where people live. And education is very important also to improve the health outcomes. So it's not only just for the education itself, but we know that it has a very important impact in education and in quality of life, and also to prevent complications and even to fight stigma and discrimination. And this is related to education to the general population, not only to people with diabetes. And of course, the role of the people that provide this education, be they diabetologists or diabetes coaches and educators, it's very important for the society as a whole. So today we are going to be having 3 of our Blue Circle voices speaking. The first of them is Riva Greenberg. She's from New York, and we are going to pass her the control of the mouse and to unmute her, and she can. There you are, Riva. Okay, Riva, so now you are unmuted. So
hi. Hi, hello from Brooklyn, New York.
Hello, Riva. We are muting ourselves, so there is no interference.
Okay, so shall I begin?
Yes, please, go ahead.
Okay, excellent. Thank you. Thank you for inviting me to be part of this topic. Of course, it's an excellent discussion to find out more about diabetes education around the world. As I mentioned, I am coming to you from Brooklyn, New York, and it's a lovely gray day here, but that will have nothing to do with our topic. Can I advance the slides? Yep, there we go. So who am I basically? I'm not a diabetes educator in a traditional sense, whereas here in America, that would be somebody who sees patients, typically in an office or a hospital or a clinic, and helps advise them on how to manage their care, including medication. But I am educating other people who have diabetes in various ways. I myself am a health coach, and I counsel people on their diabetes and their goals. I am a health researcher. I speak at conferences. I've written 3 books on diabetes and hundreds of articles. And I also help advise companies that are in the diabetes space. And so in that way, I'm very much helping to educate others and bring new information about diabetes out to people who have it. And we can advance the slide. And so the question, how did I get into this work, for me may be a very interesting one. It was not my original career. For many, many years, I was an advertising copywriter. And then at the age of 48, I was getting married, and that is me at my wedding and my groom. And something else happened that year. My company that I was working for went out of business. So those two events made me think about what did I want to do now for my work. And the idea that I was getting married, somebody cared about my health as much as I did. So for the very first time, after 32 years of having type 1 diabetes, which I got at the age of 18, I was now 48, getting married. I decided to go to a diabetes educator for the very first time. And at that visit, I realized that I would love to help other people who have diabetes. So it became my intention to work in the diabetes space. And I knew that I was not going to go back to medical school, which is a requirement here to become a diabetes educator. So I began to go to diabetes conferences where I met people and I learned a lot. And as I mentioned earlier, I became a health coach. And by going to conferences and studying about diabetes on my own, I began to write about it and write books. And so that was a great way to form me as a diabetes educator who teaches through written materials and speaking at conferences. So that really was my education and why I entered the field. We can go to the next slide. So I want to give you a little bit of an overview of what it's like for people in America who have diabetes. So most people, and I should tell you that there are now about 30 million people in America with diabetes. Most people get their education from their regular doctor, you might call general practitioner. And the time that doctors have today to spend with patients is unfortunately very, very little. A typical doctor visit can last 12 minutes, 13, 14 minutes. And so somehow they're expected to teach people with diabetes everything they need to know to take care of themselves. So something else that is covered for people on Medicare, which you receive when you're over 65 in America, is you get 10 hours of group classes. So the class may meet once a week, and you're with a group of other people who have diabetes, and that's basically how you learn, which is a very good way for many people to learn what they need to know. And yet, while the American Diabetes Association certainly recommends that everybody who has diabetes should get educated, what we know is about less than 10% of people with diabetes actually attend these classes. So if we look into why that might be, we find out that lots of doctors don't even know that they can send their patients to these classes. We know that doctors are not referring their patients out to classes. We know that the class may be far away for the person living with diabetes. And also a lot of people report that they want to be educated person to person rather than in a group setting. And so in America, the American Diabetes Association and the American Association for Diabetes Educators, which are our two most powerful organizations, are really trying to improve access. And as I mentioned earlier, 30 million people in America have diabetes. That includes type 1 and type 2, and another 80 to 90 million people have what we call prediabetes, which really is the earliest stage of type 2 diabetes for most people. So roughly 1/3 of the population here in America has either prediabetes or diabetes. We can go to the next slide. So in America, there is no clear path to become a diabetes educator. It's not like you can go to school and take a program to become a diabetes educator. So some of the criteria to go into this career is one must already be a medical professional, which means you either have to be a doctor, a nurse, a dietitian, a pharmacist, or you can be an exercise physiologist or a behavioral health therapist. But you must already have a degree, and you must already have 2 years experience in one of those fields. So you must have worked in your field for 2 years, and then you need another 1,000 hours of working in diabetes education, actually tending to people who have diabetes. And lots of people just get that as on-the-job training. They're already working in a hospital or a doctor's office, and they begin to work with people who have diabetes. And after you've fulfilled this criteria, if you want to become what we call a certified diabetes educator, you must take an exam, and you must renew your certification every 5 years, and there are costs involved. Like I believe it's $350 just to take the exam. And then you need additional education every year, which typically you have to pay for. And there is no government support, no official government support. So one really comes to this work out of a passion. And we see that all the time when I meet with diabetes educators. They are amongst the most passionate people I know. And their workplace typically is hospitals where they see people, and clinics and doctors' offices. And a growing way of delivering care in America is through telehealth, through the telephone. So you might be a diabetes educator working with a person who has diabetes over the phone. So we can go to the next slide. And so I wanted to give you a little bit of a sense now of what the environment is like in the States, because I mentioned the overwhelming population. In fact, I believe behind India and China, America is the third country that has the largest population of people with diabetes. And so we start looking at why is that? And of course, we know that while obesity may not be a cause for diabetes, we know that there is a link between being overweight and type 2 diabetes. And the statistics tell us that almost 75% of men in America are overweight or obese. And I was actually surprised when I looked at these statistics and how they broke them down into male and female. More than 60% of women are overweight or obese, and no more tragic, but equally tragic, is nearly 30% of children today are overweight or obese, which is, you know, just really, really a terrible situation that we're working with. And I give you a couple of reasons why this is the case. So we can go to the next slide. So, yeah, we can hold it there. That's okay. So one of the things I put down is the rising cost of insulin. In America, we're having a terrible time. We're having a lot of advocacy around how expensive insulin has become. And somehow it's not just the pharmaceutical imposing high prices for insulin, but the way that the medication gets to patients and how many hands it has to go through has made the cost of insulin 7 times more expensive today than it used to be. And that means you could end up spending hundreds of dollars for a single bottle of insulin. And the only 6% refers to the fact that only about 6% of doctors give their patients a referral to see a diabetes educator. So there are actually 20,000 diabetes educators in America, which on the one hand sounds like a lot, but on the other hand, for a country of 325 million people, it's not nearly enough. And unfortunately, they tend to congregate in the larger cities in the United States. So there are a lot of people who don't have a diabetes educator anywhere near where they live. And the fact that only 6% of doctors are referring their patients out to educators is a big reason why people never get the education that they need. And we could put up the rest of the information on that slide. And so when we look at our food environment, most farm subsidies go to producers of corn, soybeans, and wheat, cotton, and rice, which means that these food items are going into most of the consumer products in America, fattening them and fattening us. We are only, I think, 4% of subsidies go to growing healthy foods like fruit and vegetables. And I put up this box of breakfast cereal as an example because most Americans start their morning by eating a bowl of sugar-laden breakfast cereal. And 1 gram of fat in here and 47 grams of carb. And yet we're telling people, if you're able to look at the label on the box of cereal, that this is a heart-healthy food. So this is part of the environment in which we live and part of the reason why people are getting heavier and heavier. So we could go to the next slide. Thank you. So in my work, I said I speak at conferences, and I do that both for people who have diabetes and also health professionals. This happened to be one of our IDF World Congresses that was in Melbourne in 2013, and we had a seminar for the young leaders where I was working, and it was a great opportunity to really work with people and help them understand that, you know, diabetes requires an awful lot of work to manage, and yet there's so much good news happening today in the space of all the tools that are coming out and devices. And also, we can be very strong in how we live with this condition and look at our own strengths and resilience. And I have spoken to many, many people with the condition who are absolutely doing very, very well. And as I like to say, flourishing with diabetes. That takes us to the next slide. So I also train health professionals, and what I've been doing over the last 3 years is working around the world at diabetes conferences and helping diabetes educators and nurses, sometimes doctors, dietitians, work with people who have diabetes in a new way. So rather than being focused on the disease and the problems that a person may be having, we are actually creating a human connection with patients. And we are helping them see their strengths, and we are involving them in the treatment plan. And we are coming from sciences that are based on how individuals actually behave and what brings out the strength and resilience in people. This conference happened to be in Copenhagen, where I'm returning in 2 weeks. I've been invited back to give this presentation workshop again, and that's fantastic. So we're beginning to help educators work with patients in a way that we believe will help people with diabetes do even better with their care. And I'd just like to close with the next slide. This was actually when I was working in Bangalore at a diabetes clinic for the poor, and I was there for 3 weeks, and I was teaching the medical staff how to work from this flourishing approach. This happened to be one of the dietitians, and the day after I gave a class, on Flourishing, she came running over to me, giggling, saying, wow, I just have to tell you that I just worked with a patient that I see often, and I started working with him in the way that you suggest. I started helping him see how much he's really doing well, and we were smiling throughout the whole visit, and he just left, and he's so excited to take the next step that he came up with himself. And so it was just a wonderful, wonderful moment to get that feedback. So I just want to say I am so blessed to be in this field. I am so fortunate and grateful that this is the work I do now. And again, thank you for being part of this webinar.
Thanks a lot, Riva, for sharing your experience with us. It's really sad to hear that a country that is so rich and that has such a big problem with diabetes. You are saying that a third of the people living in the U.S. are at risk or have already diabetes. And, well, it's clear that the authorities are not doing enough on education, so your role is even more important.
Yes.
So we are going now to move to the next speaker. So now we were seeing that, that Riva was in India, and the following speaker is actually a person from India that will explain us her experience in her country. So I'm trying just to unmute Gopika. Can you hear us, Gopika? Hello, Gopika? Gopika, I'm not sure if you can hear us. We cannot hear you. No, I'm seeing Gopika is writing on the screen, on the chat, sorry, but we cannot really hear you. The line is not working. Yeah, maybe let's try that, Gopika. I will just remove you from the webinar, and then you can join again, and let's see if it works. We already tried before, and it was like that. Okay. Okay, so apologies for this to the people who are attending. We're trying to solve that. Meanwhile, maybe we can explain why we chose these three countries that we are treating today. So we have Riva from the US, we have Gopika from India, and we have Jane from Kenya. So we wanted to have people, well, first of all, from different geographical regions, but also that come from countries, that are different. So, for example, we have Riva that comes from a country which is a high-income economy, and then we have Gopika and we have Jane that come from countries which are lower middle-income economies. So initially we should think that their experience is different, but actually we are seeing that in many countries, governments do not really pay enough attention to diabetes education. So it's not really that much about the income, but many times about the political engagement the governments have in it. Hello, Gopika, we can hear you now. That's great.
You can hear us, so thank God.
We're going to mute ourselves. Please go ahead.
Shall I go ahead? Hello?
Yes, Gopika, we can hear you. Please go ahead with the presentation, yes.
Okay, thank you. Thank you so much. And thank you for inviting me to this webinar. Let me introduce myself. I am Gopika Krishnan. I've been working as a diabetes educator for the past 9 years at a comprehensive diabetes specialty center in the southernmost part of India. It is in Trivandrum. Can I have the next slide? So as you are aware, India is only second to China with the maximum number of diabetes patients, and my state, Kerala, is supposed to have the maximum number of patients, diabetes patients in the whole of India. So, so I joined the center. It's a comprehensive care center soon after my bachelor's in pharmacy, and my intention was initially to gain some experience before pursuing my higher studies. So in fact, it was my vacation days, and however, this field took to me by surprise, and the exposure in this field changed my career goals. My mentor, is Dr. Zubide. He always used to tell me, and my fellow diabetes educators, that the role of diabetes educator is much more than a doctor treating diabetes. And when I started seeing patients, I was shocked. They were having very high A1Cs, they had complications, and slowly I realized that the failure of diabetes treatment is not due to the lack of medicine, but because of lack of awareness, education, and there's a lack of training. They don't know how to inject insulin properly. They doesn't know how to take their medications properly. And coming in terms with this reality, I decided to become a diabetes coach. Next slide. Yes. So I underwent training and I became a certified diabetes educator and also an insulin pump instructor. And years went by, I got married, and during my first pregnancy, diagnosis of GDM was made. It came as a shock to me. I had a normal migraine, I had no family history of diabetes, and it was an eye-opener. And it made me realize the huge risk of being of Asian Indian ethnicity. And I was started on insulin injections, and this experience further strengthened my decision to be a diabetes advocate. I started taking my experience in various forums, and I've been this profession for the past 9 years now. Next slide. Let me explain my roles. I play multiple roles because I have the opportunity. I'm fortunate to be working in a diabetes specialty center, and at the same time, I also have the opportunity to work in a community setting. So I'm in a diabetes specialty center. I'm part of a multidisciplinary diabetes team, and I'm also part of research related to diabetes. And in the community setting, I am part of a team. It is known as the Diabetes Screening Kerala. It's a big team conducting diabetes screening, detection, and treatment camps across Kerala, and where we see a lot of those socioeconomically challenged patients with diabetes. Next slide. Next slide. Can you hear me? Yes. Before I move on to explain the scenario in both these settings, let me take you to the status of the glycemic control in India. As you can see from the numbers here, the HbA1c, the average HbA1c is 8.9%. The random blood glucose is 193. The fasting is 147, and the postprandial glucose values are somewhere around 205. That is the average. And it is shocking that only 19.7% of people with type 2 diabetes have good glycemic control in India. So, this was a study done in different multi-specialty diabetes centers. The center was not part of the study, but it is really shocking that even in multi-specialty centers, in diabetes care centers, the scenario is worse. Next slide. So in my center where I work, it is a diabetes care center. It offers a telemedicine facility. It is called DTMS. It offers DTMS, the telemedicine facility, round the clock for its registered patients, and it has been documented to be cost effective in preventing the complications in diabetes, and we have several publications on DTMS. And let me tell you, this is one of the few diabetes centers where a multidisciplinary diabetes team is involved in patient care. We have the diabetologists, we have nurses, we have dietitians, we have pharmacists, we have psychologists working in this team, and we follow up the patients based on a set frequency. We follow up the patients, and the success rate of the diabetes managed at our centers is 86%, which is a very, very huge rate, whereas in the community it is just 4%. Next slide. So this is an overview of the diabetes tele-management system. The patients will be reporting to us all the 4 blood sugar values, that is the fasting, the postprandial blood sugars, and 3 a.m. value if necessary, and they'll be reporting it over phone or over email or over the internet through a secure website. And based on the blood sugar values and the dosages, we'll be titrating further their medications, and we'll also be providing specified customized diet advices and exercise advices, and based on the values, we'll be setting a target for all the patients. It will be individualized, and we have a unique software where all these readings, all this data are entered, and this is a unique system. Next slide. And the cost effectiveness of this system has been proven, and this was a publication that has appeared in Diabetes Technology and Therapeutics, where we could achieve the target HbA1c levels without serious symptomatic hypoglycemia in around 1,000 patients with type 2 diabetes. This was a retrospective study. So it was one of studies which showed that they never contracted any complications of diabetes. Next slide. So having explained the scenario in my setting, let me explain the scenario in a community setting where I often work with. I visit these places during my camp, during the camps that we conduct. Those camps are the diabetes screening and detection camps, and I get to know the grim situation in the majority of the areas in India. I visit these camps. There is no multidisciplinary team, and so no education is imparted to the patients on the various aspects of diabetes management, and it translates to poor treatment outcomes. We see a lot of patients who have already have complications, and there are no reimbursement policies, and even the type 1 diabetes patients doesn't get the treatment free of cost in these settings. And as you can see from the picture, there is one of the camps that I attended recently, and on the right side there is a picture where I met a lady, a patient who had injected on her arms, and there are lipoatrophic areas on both her arms because the doctor never told her that she shouldn't be injected on part of the arm. And given the huge number of diabetes patients, the resources are really limited because on an average, a doctor in his daily OP will see 300 patients in an hour. So huge is the number of diabetes patients and teachers in OPD that they have no time, practically no time for diabetes education. Next slide. So let me move on to, I think this slide should have come earlier. In my diabetes specialty setting, the challenges that come across is that I get stress. There is a lot of psychological stress induced by the patient experiences. Those kids with type 1 diabetes, and it requires a lot of commitment and a lot of time. And since we give round the clock advice to the patients, my involvement is almost round the clock, and it is beyond working hours. I might get a call at night, even at night, from a patient who is suffering from a low sugar or who thinks that she is having a low sugar and episodes are endless. So a lot of commitment is required if you are working in a diabetes specialty center in our setting. Next slide. The major challenges while working in a community setting is that you feel The average A1C is very high. There is no involvement of a multidisciplinary team, so only a prescription is given by the doctor. Not even the patients are never advised on how to take how to take these medications, where to inject, how to inject. All the no tools there. And policy makers, the government is still aware of the role of a diabetes team in managing diabetes, and the focus is still on treating the complications rather than preventing the complications. So that is a grim situation in a community setting. Next slide. And if I speak about the country-specific challenges, and there are a lot of storage issues with insulin. The injection techniques are not taught to them properly. There are suboptimal dosages. There is an inertia from the part of the clinician to titrate the dosages, to increase the dose of insulin for fear of hypoglycemia. There is a reluctance from the patient to start insulin because they are not properly motivated, they are not properly educated on the benefits of starting insulin quite early during their diabetes duration, when it is really early. They must be starting insulin, but this is not properly taught, and they are not properly motivated, and there is a lot of depression, suicidal tendency in type 1 diabetes patients and kids and adolescents. And if you speak about in the case of women with diabetes, they face the priority illness, which is the responsibility of the family. There will be 2 kids in the family, or usually three kids will be there in the family, and the mother will be taking care of the children and husband, and ultimately her diabetes is poorly taken care of. And there are a lot of unscientific therapies to make therapies. Some of them will drink some bitter gourd liquid, some Ayurvedic treatments will go. Not only Ayurvedic, just some unscientific treatments will go for, and ultimately the diabetes management will fail. And though it is good that we have a lot of festivals, there is a lot of harmony among the different religions. We have every festival for every season. That means that you will have a lot of sweets during every festive season, and after festive season, when the patient visits the clinic, you can obviously see that their HbA1c is high because they have taken some sweets, probably more sweets, because every time they'll be forced to have sweets during this festive season. So that is also a major challenge. Next slide. So how do we overcome? In our clinic, we practice one-to-one as well as group diabetes education. That is the key to success. We'll try and identify areas which require reinforcement, retraining, and recently we have also started providing diabetes educator courses for those fresh candidates who are out from college, that they can be motivated to become diabetes educators. We provide them free of cost, and we have newsletters for the past 10 years that is called the Diabetes Gems. So it will provide updates on all the recent technologies in diabetes, and also promote healthy lifestyles. Next. So let me conclude with this. The millions of subjects newly diagnosed with diabetes in my country, and in this scenario, we need to elevate the diabetes. We need to elevate diabetes education to the next level. And diabetes education and coaches are pillars of success in diabetes. And as diabetes educators, we must spend more quality time and customize the education to each patient, because the need of each patient is different, and there must be tailored treatment for each and every patient who visits your clinic, and playing an active role in the change life of those with diabetes. I am an example of this. And appropriate continuing education and comparable services should be imparted to diabetes educators to ensure continuing competence. Thank you very much for your patience listening. Thank you.
Thanks a lot, Gopika, for sharing your experience with us. So it's something very, very interesting today also that our 3 speakers, apart from being diabetes educators and coaches, also they have diabetes themselves. So of course they have the personal experience, and that's very important for the people that they are providing education to. So now we are moving to our final speaker of today. I see that some people are writing some comments and questions on the chat. So when our next speaker finalizes her presentation, we will be having a Q&A session. So I'm just sharing the mouse control with Jane, and I am Hello, Jane, can you hear us? Jane, can you hear us?
Yes. Yes,
okay.
I am.
Great, perfect. So you can start your presentation already. We are going to mute ourselves, so the line.
So thank you once again. I'm happy being here with us today. And the purpose of this webinar, as all of us you can see, is diabetes education. I'm here so that I can talk on diabetes education in Kenya. I'm a co-founder and a program coordinator of an association known as Kenya Diabetes Association. This association is actually diabetes, enjoying that 8 years now with the please. So here in Kenya, of being or living with diabetes, I thought that it is nice to bring people living with diabetes together. Why? It is because here in Kenya, actually, as I have to others, my other colleagues, here diabetes education is a bit very low, if I can say that. And that's why me and that we thought of coming together, forming an association. And here is with the full knowledge of the Ministry of Health in Kenya, Division of Non-Communicable Diseases. And bearing in mind that our endocrinologists are very few number in Kenya, they are less than 300. They may not have even that hard time because we know that diabetes is a lifelong condition. And actually due to this, the increased number of people with diabetes and the shortage of people of health providers, I personally felt that it's good and approach the ministry on how we can start diabetes education, since that is the next option. As you can see in the diagram below, they are having a large number of people in different areas, especially in rural areas, where diabetes education is a problem in our country. So you can see there are elderly people where I'm giving a lecture on awareness with diabetes. All these that you can see seated with in different places, all of them are people living with diabetes type 2. Next slide, please. And as we know, the purpose of being a diabetes educator, mostly you are either a health professional or a specialized person. Specialized in helping people, in teaching people with how to live with diabetes and to manage diabetes. As we know that once you are newly diagnosed with diabetes, a patient-centered healthcare team is needed. But is it really there in our country? No. That's why people living with diabetes will turn to a diabetes educator who can be able to give them the support that they lack from the health team. And we really see that the diabetes educators are becoming the next resourceful idea, whereby they will have enough time so that they will be able to speak and to share their experience with other living with diabetes like them. I thought of the idea and suffering of living with diabetes because since I was diagnosed, my first awareness or my first seminar, I got it in 2005. Other times, you just admitted in the ward. Other times, you just been told to go and inject yourself. But there is no that personal touch with the healthcare provider who is guiding. Here, I think it is because of the shortage and also the lack that time. Actually, in Kenya, we are just about 300 diabetes educators. In a country where we have more than 2 million people living with diabetes and more than 4 million who are pre-diabetes. Next slide. As you can see in those diagrams, this is a class whereby we were training people, that is other people living with diabetes. We call them diabetes peer educators. These, they are trained, they also do the same in the community. This training is not done in urban, it is done in rural areas because these are where problems are. We also do screening. You can see me there, screening. One of our governors in one of our counties, as in our country we call them counties, so that actually people may have early diagnosis, and once they know themselves early, they can be able to be helped. The other diagram is a class of peer educators where we are training so that we can be able to understand ourselves. Still, you see that diabetes actually is a problem even to type 1. You can see that I'm there giving a nation of syringes to diabetes type 1 who have been suffering, injecting with only one needle for more than a month. So this is actually an area that we need to check, and we are getting this in our country because type 1s and those who inject themselves, they are really suffering. Next slide, please. Next. Now, if you look at the role or the purpose of an educator, I being one and the other colleagues that we have talked with, many are the areas that really we require to understand very well. For example, we have a formula in Kenya we call NEST. In this formula, N stands for nutrition. We know that if you are able to understand your diet properly, thereby you are going to do away the junk foods away, you will be able to treat yourself more than 60%. That is more than a half. You will be able to manage your diabetes very well. When we do exercise, we know that this one will help you in elevating or actually in managing your levels very well, your blood sugars very well. That's why the type 2, and I'm saying in rural areas, they even don't bother with exercise. But in education, we show them the exercises that they can be able to do and the ones that will help them to manage the sugars. We do also monitoring. For us here in Kenya, once you are given a clinic to go and see your doctor, you'll be given a clinic after every 3 months. Then what will be happening in between the 3 months? So we require to educate that person living with the diabetes on how he or she can monitor herself, monitor the sugar levels, monitor the blood pressure, monitor the exercise that you are doing, and also the foods that you are taking. And the three, the character in NEST is the treatment. What is the purpose of this? As a educator or a diabetes educator, you require to share your experience with others and to show them the purpose of following their medication properly. That is compliance. Many other times, people living with diabetes, me being one, many other times you'll find that you follow your treatment. Maybe you only follow your treatment when you approach your clinic so that the doctor may not complain. There is stress and we cannot do away with this. Because we are human beings, we are living with a lot of problems. And actually, like in our country where now we are really trying to grow up, and therefore we need to show that person, despite the stress that is there, how are you going to solve those problems so that your sugars may not be elevated due to the stress? Also, in the education, there is a need of showing them how to reduce the complications. We know that with proper management, they will be able to survive for a very long with diabetes and with no complications. So once they are educated on how the person can be able to manage the sugars, how to keep your A1C very well controlled, then you'll be able to live a free life with no complications. Second is actually staying positive. The major here with diabetes, and I'm very happy. For my 38 years with diabetes, I know that more than 25 I've been living with a lot of conditions. But since I now started attending the trainings, I started attending the workshops, I can tell you that my life is sweet. Even my young ones, my kids, can tell you that I'm a changed person because you understand very well how to live with it. Next slide, please. In those pictures, you can see the first one. I'm showing them how to exercise. And you can see there is a woman seated there. That woman actually is on a wheelchair. But even if you are in a wheelchair, there are simple exercises that you can do so that you can relax your muscles. The second diagram, this is showing them in a class how to use an insulin needle when you are injecting yourself. These are big problems to our people here in Kenya. Most of us, when we are diagnosed with diabetes, the pharmaceutical, the pharmacist, the one who shows you how to inject, most of them, they use a knowledge. So once the user applies our knowledge, you will not be able to get it well. So when we are doing the trainings, one of the things that we are doing is to show you how to inject yourself, how to draw insulin from the file, how to store your insulin because this has been a problem, and also how to rotate the areas of injections so that you may not have the one we have seen in that picture from my dear colleague in India. Then for the purpose of self-monitoring, through partners, not through the government, but through the partners, we have been able to be provided with self-monitoring equipment. Like in the picture you can see, there is a glucometer, there is BP machine, there is weighing scale, there is height meter. All these are provided to groups because what we do, once we realize that in a certain area there are a number of people living with diabetes, we form support groups. This is where you provide them with self-monitoring items. If we go back to the other picture, once the training is done, the diabetes educator is provided with a curriculum, the one that he should be following once he is training other members in the groups. Next one, please. Next one. Many are the challenges as of here diabetes data. The one of the frustrations that I can solve is frustrations. And these frustrations come from here. You have journeyed with a person living with diabetes. You have come with a very good plan together with her or him on how to attain a good control, but unfortunately, complications strikes. So you feel that really you are frustrated due to this. The other one is the understanding capacity, especially in rural areas. And as I'm giving an example, that in Kenya, diabetes education in rural areas is very poor, less than 5%. So it means that even to the small group that you approach, you need a lot of work. Try to look at the language they can understand, because you need to explain to them in a language which they understand, and they will be able to remember once they are alone. The other one is means of transport. As I have seen even from all other my colleagues, the government does not take any hand in this. So you require to move from one place to the other, even doing home care, to those already with complications, and because they are part of you, you feel that you require to go to where they are. So many other times you struggle in transport. Then there is another challenge, and this is a very key one. I don't know whether other colleagues in their countries they have this problem. Myths and the misconception. Remember that many other times, if people living with diabetes, or if you are living with diabetes, you don't understand really what is happening with you. And the doctor will just tell you that now you are in a condition, you are in a disease. Actually, they tell us that it's a disease. And in this disease, you are going to live with it. Don't you arrive, you are there. What kind of a disease that I'm going to live with it until I die? So if actually a proper information is not given to you, you look for alternative answers. And alternative answers will look at the myths, we look at the conceptions, which many of them are harmful. Like in our country in Kenya, many people think that it is witchcraft. So it is good that they have this proper information. The other major challenge is lack of resources. As we said, that the government is not taking hard in, while there are so many good programs for diabetes that are required to be taken care of. We have a and due to this, you'll find that many other times you'll struggle alone. You can see those challenges here in the first picture. I'm traveling with a motorbike so that I can visit people in rural areas. The second picture, a woman here, already who has been amputated, and we had been journeying with her. In the last, you can also see the other one is suffering from food. In the fourth picture, that woman who is at the middle has just lost her eyesight after a very long journey with her. And to conclude, we usually say that our purpose in this life is to help others. And if you can't help them, at least don't hurt them. That's why we are really struggling as diabetes educators. As I have heard from other colleagues, to help others, already we are wearing the shoe. We are living with diabetes, and thus we know that the shoe really pays. Thank you.
Thanks to you, Jane, for sharing your experience with us. You are indeed helping a lot of people, so thanks a lot for that. It was really great to see all the pictures of the activities that you are carrying in your country. Okay, so I'm going to unmute the other two speakers, and then we will check the questions that some people were having. So let's unmute Gopika and let's unmute Rita. And now let's see, a few people were writing. Okay, so we have a comment from Osharenko. She's from Nigeria, and she's also a BCB member. She's saying that she's really amazed at the great work that you are doing, and she has been doing, so basically she's also a diabetes educator, but she does not have the certification, so she's been teaching people in Nigeria about diabetes, and now she's saying that she's proud of all the speakers. So, I don't know, Riva or Jane or Gopika, if you have any comments for Sharon Cohen.
I'm happy with the information. I'm happy because she is doing it. And even if you do not have a certified certificate, please help people because you understand from in what it means. Thank you.
Yeah, maybe Riva can take this one. So actually she has a question. She's saying because she does not have a certification on diabetes education, she doesn't feel good calling herself a diabetes educator. So she's asking if maybe it's better that she refers herself as a health coach. Riva,
so Sabine, one thing is, it's very funny because sometimes I have the same issue. Do I call myself a diabetes educator because I don't operate in the way that we think of? that diabetes educators operate with individual patients. But the truth is, if you are helping people with diabetes learn more about their condition and how to help themselves, I think you are definitely a diabetes educator. And there are different ways in which you can do that. And one is definitely by being a health coach. We could definitely call you a diabetes educator if you have the knowledge, which I'm sure she does. And another way, I don't know in Nigeria, but in America, I was what we call a peer mentor for 10 years. So one of our big pharmaceutical companies, Sanofi, sponsored a program where there were about 80 people who had diabetes, were all trained to go across the country and educate other people with diabetes, largely who met in monthly support groups. And so we were called peer mentors because we have diabetes ourselves, and we were teaching them how to better educate themselves. So if there is such a thing in Nigeria, perhaps she can look to see if there's a way for her to be a peer mentor.
Okay, so Osarenko, there you go, a tip for the future. Narsima from India, he has a question. We need to publish certain list of educators because when it comes to serve the needy on diabetes, educators need to come voluntarily to serve. So I don't know, Gopika, I think she's having again some problems with the line. Can you hear us, Gopika?
I can hear you clearly. Can you just type so that I can reply?
We can hear you super well actually now.
Oh my God, but your voice is all mixed up, so I can't make out what you're speaking.
Yes, so Narsima, he was saying, he's from India, the same as you, and he was saying that he's from Telangana,
Okay.
and he conducts a lot of camps. So he's saying that maybe it would be a good idea to publish a list of educators to search for volunteers.
Hello? Can you repeat?
Yes, we can hear you. Yes, so he's saying that in 3 months, they have screened 15,000 people in Telangana, in India.
I'm so sorry about that. I can't hear you. Can you just type?
Yes,
Is it
okay. We will,
yeah.
Okay, let's type that response to Narsima. And those were all the questions today, actually. So it's very interesting.
I saw the question. I'm from Telangana, India, because I conduct mini camps already in 3 months, 15,000 people. Yeah, amazing job. So what I understand is that we have a lot many camps being conducted across the country by different associations. So they are doing a beautiful job because many a time the screening is never happening in our country because the patients will be visiting a clinic very late, only after they contract some of the complications of diabetes. So this screening means they at least know that they have diabetes. And probably in these camps, in our camps, we provide some free medications for them so that they are at least on 1 or 2 drugs. Probably for diabetes, for high cholesterol levels, if they have high BP, we provide them with BP medications, cholesterol medications. So at least in these camps, these medications are provided. Otherwise, these patients will never be diagnosed with diabetes. They'll only know that they have diabetes after they have some complications. That's a great job that you're doing. Thank you.
Yes, so Gopika Narsima is now saying that he has developed a mobile application.
Mobile apps are there in umpteen numbers, but in local language means you can reach out to many of those people who doesn't know English. So that's again a good job that you're doing. If you can give me your mail ID, we can get connected.
Okay, so what we will do, actually, we are going to be putting these slides on our website and also on the BCB Facebook group. So Narsima, you will be able to check on the slides the email from Gopika because she has written that in the presentation. So, well, thanks a lot to all the speakers today, and also to all the attendees, because I'm seeing here that actually a lot of the attendees are also acting as diabetes educators in their own country, so that's great. And yeah, just as a conclusion, we were saying before that we were having people from these three countries, from the US, India, and Kenya, because they are countries, well, with a different level of income, and maybe their experience was different. But actually, well, we see now that diabetes education is failing in most of the countries. So very rich countries are not doing that well. Riva was saying that only 10% of people with diabetes in the US actually access this education. In Kenya, there are only 300 diabetes educators for the 2 million people that have diabetes there. And also in India, Gopika was saying that there are by far not enough healthcare professionals and educators. So, of course, this is something that we need to continue working in. As you know, IDF is very engaged really in education. We know the importance of it, and we will, of course, continue advocating to all governments around the world for them to improve diabetes education. We think this is something very, very important. And for that, we will, of course, need for sure the support of all our network, from our BCBs and from our YLDs. So we will continue working together to achieve better education everywhere in the world. Thanks a lot for joining the webinar today. And let's speak soon for another webinar on an important topic. Thank you. Bye.
Thank you, Sabine.
Thank you.
Thank you. Bye-bye.
Thank you so much.